and also to take us into our next literature session. Thank you.
Good afternoon, everyone. I hope you're enjoying the course. Or it's been a waste of time. Well, I hope with another day to go, things will settle in a little bit better. I'm certainly enjoying my time with the students I have. It's both ways. They teach you something, and you teach them something. So it's always useful to have an interaction. This afternoon we have a session where we're going to interact with friends of ours who are experts in their fields, and some of us, we are hangers-on. We hang on because we're not really emergency medicine people, but we share an interest in emergency medicine. So we've arranged for a session this afternoon to share ideas, as we stated yesterday, like what Dr. Mpoki said. And I would like to repeat what he said to a certain extent, which is what we say to many of our participants. Study, read, do other courses. These other courses are the ones that brand you. There's no difference between you and the other medical student or the other nurse next to you. If you don't brand yourself, you got to brand yourself. You brand yourself by doing things that others have not done. Currently in Tanzania, we have a lot of young people who are doctors, but they have no places to function from. They're unemployed. It is sad, but that's the truth. So what do? We try to find alternatives for these young people. One of the ways of finding alternatives is to train courses that are worldwide accepted. Because the worst thing is to ask to apply for a job in Zaire and then be told, we don't recognize your medical school. We don't recognize what you did. Okay, so you look like you have an inferior certificate or diploma or qualification than the guys who are being employed. I can tell you we have friends in EMSA who are working elsewhere, outside the country. And they're working there because of the strength of some of the courses we are training. Do BLS. Do SCLS. You cannot get a job outside without those qualifications. Sorry, but that's the truth. We can't hide it. The first thing they'll ask you is, have you done BLS? No. Have you done SLS? No. Sorry, we don't have a position for you. And that is even within the country. That has gone up to within the country. Aga Khan Hospital will not employ you without those qualifications. The oil industry will not take you without those qualifications. The mining industry will not take you without those qualifications. Now, surely, a course which is about 1 month of duration and you can't do it, what do you want to do? This is the way, this is the approach, this is the available avenue for us. Do those courses. I'm not saying that because EMSA is teaching those courses. Aga Khan teaches those courses. You can go to Aga Khan, get your qualification there. Muimbili teaches those courses as well. Go to Muimbili, get those qualifications. But please do something that makes you more marketable, more than what you can be offered in the country. Right now, we are too many. The positions are too few, like what Dr. Mpoki was saying yesterday. Not that they are not there, the positions there, but the government can't employ you. So, please pay attention to what we are saying. I'm just trying to go over what Dr. Mpoki said yesterday. Make yourself marketable. Brand yourself. What makes you stand out from all the other MDs that are there? What will make an employer seek you, choose you, select you over the other person who's next to you? Is if you brand yourself. So that's what we are asking everybody. brand yourself. Take time to brand yourself. Make something unique about you which attracts people to you, and therefore you get opportunities to do. America, Canada, yes, they are there. Places are there. But they have got exams, and I can tell you one of the exams is just like BLS, SCLS. But if you tell them that you've done BLS and SCLS, they will understand what you did, because this is worldwide. Everybody knows what SCLS is about. And it's taught exactly the same. Here, America, South Africa, it's exactly the same. My last word, let's read. Dr. Fire is still reading. Let's read. The only way to perfect ourselves is to be equal with the rest. So let's read. There's no harm in reading. It's very sad that we should see young people and they are not reading. We are not reading. I'm sorry, I'll say that again. We are not reading. People come to these courses and they haven't read not even a single book. Read anything about ECG? Come on, surely. You want to do BLS and you didn't even touch the book. You came with the book the way it was given to you, that's exactly the same way. Some people are accessing it on the net, on the night before the course. I can't access this material. So I have problems. Come on. You're not reading. If there is a word that I'd like to leave with you is read. Not social media. Read something serious. Because it's there, it's available. It's not like during Dr. Fire's time when we read under the mango tree and things were difficult to find. I have books in my house. I don't know what to do with the books. Nobody wants to read the books. They read it on the net. Fair enough. But even the net, they don't read. They read social media. My last words are those. Let's read.
They have wisdom and they have a lot to tell us. He might say last word for 3 minutes and be 30 minutes. Let's put our hands together for his wonderful presentation.
Thank you so much for BSV, Bharat Serums and Vaccines Limited. First of all, thank you very much, Dr. Ramadani Chunga, for organizing such a well-organized training programs for the young minds. It's definitely need of the hour. Okay. Having said that, thanks to EMSA as well and Dr. Marco and Baraka, who has invited us to be a part of this, and to all the HCPs for participating. Okay, so yeah, so I'll just give a brief about our company and what is our goals and what is our specialization. Okay, our corporate overview and capabilities. We are a company with a journey of 50 years, let's say 50 glorious years. A leading biopharmaceutical company driven by science and innovation and people as well. We have a strong research and development and manufacturing capabilities of biopharmaceuticals. We have partnership with global academy as well, and we have global patents for products like anti-D, immunoglobulin for mothers with rhesus negative blood group. And our core competencies are clinical trials, or clinical research from phase 2 to phase 4. Human trials also we conduct for many of our products. And we have research and development in biotechnology, biologicals, novel drug delivery systems, and we have clinical studies as well, animal studies in disease burden or disease models, and technology of dose dependent regimes as well, and studies as well. And we manufacture biologicals and biopharmaceuticals in bulk, and we also have implant technology manufacturing as well. And we manufacture urine derived substances as well. And our R&D, we have like 75 scientists based in our India and Germany R&D centers. And we are the pioneers over 3 decades in manufacturing biopharmaceuticals, and currently we are #1 when it comes to innovation and technology. We have strong IP capabilities. We have multiple patents granted and filed across the world. It's not only in India or a particular country. We are there in countries where patents are filed are Brazil, China, Saudi Arabia, South Korea, and United States of America. Countries where patents are already granted are Australia, Eurasia, Canada, Europe, and South Africa. These are the countries where we already have patents. So we believe in innovation and technology and bringing life to the patients. Why we are saying bringing life to life? The products where we deal with mostly are into women health, critical care, and emergency medicine, where it is always saving the life. And we also have products related to infertility hormones, where again those parents who are not able to have children, we are bringing a life to their life. So when it comes to the crowd today, we have our critical care medicine for patients with invasive fungal infections. We have sepsis related products, pancreatitis, cerebral thrombosis, and also acute DNT, etc. We are the first in the world to launch anti-D, which I have already told you. We are the first in the world in India to launch urinary trypsin inhibitor. We collaborated with the professor from Japan, and we licensed their product. And we are the first in India to launch antithymocyte globulin equine, and soon we will have our rabbit formulation as well. And we are one of the first in India to launch human immunoglobulin, IVIG. And we are the first in launching generic implant of amphotericin B liposomal. After the innovator, we are the second ones to launch this. So what is our quality standard and certification? Many at times companies will come with bare minimum, whereas we follow the highest of the highest standards. We are WHO GMP certified, British Pharmacopoeia certified. We follow PICS standards, which very few companies follow, and we have EU GMP as well when it comes to standards. And most of our products, they have to have a special storage system that is between 2 to 8 degrees centigrade, because they are biologicals. And for that, you need to have best of the best cold chain. Otherwise, it won't help the patient. Okay, that's why we follow WHO good distribution practice, and we follow pharmacovigilance guidelines, and it meets international guidelines as well. So why it is important? I'll just give you an example. Last year we received antithymocyte globulin, which is used in aplastic anemia patients. If that doesn't work, the patient will die. Okay, and unfortunately in Swissport at the airport, they stored it at -2 degrees centigrade. Okay, if we release that batch, the patient, whoever is spending, let's say 10, 20 million or 40 million to buy this, will not survive. As an ethical company, we had to take that loss and tell them destroy the stock, and we had to bring another new stock. So that is where the difference makes. It is not a matter of making only money, it is also a matter of providing the best service to the patient. So that's what we believe in, that's why we follow WHO guidelines for cold storage. Okay, our key brands, as I told you, for critical care, it is ulnastatin, our U-Trip. For sepsis patients and acute pancreatitis patients, it is given as a co-prescription with our other antibiotics, like let's say meropenem or whatever other products you are prescribing. Basically, it's a enzyme produced in our body and excreted through urine, which is then synthesized in the lab and given to the patient to reduce the inflammation. It works as an immunomodulator basically. So that is there, and then we have amphotericin B, lipid emulsion, which again used in invasive fungal infections. It is a lipid emulsion formulation, slightly economical compared to the liposomal, and slightly higher nephrotoxicity, that is 0.3% higher in nephrotoxicity compared to liposomal, which is again our patented product. We have amphotericin B liposomal as well, Amphonex, which because of the royalties involved with the patent, it is at a little bit higher price. And then we have polymyxin B for your multi-drug resistant patients, even in sepsis or burn injuries. It is a very good product. Wherever your meropenem fails or your other high-end antibacterials fail is when polymyxin B can be prescribed. And most of your hospitals, we have already given the e-test strips so that a culture sensitivity can be done and then polymyxin can be prescribed. Okay, so these are our range of products currently available in the country. And these are the awards and recognitions we have received across the world for our innovation, quality maintenance, and the pharmacovigilance which we maintain. So with this, I conclude my session, and thank you very much. Yeah. One small point I want to add. Recently, our IVIG and antithymocyte globulin equine has been entered into NHIF. So those patients who are suffering from GBS, Kawasaki syndrome, etc., you can now give them gamma IV and antithymocyte globulin in NHIF. So many patients you can save their lives. Okay, thank you.
Thank you very much, Mr. Sai. In case there are questions from the audience, please you can share them to EMSA, our WhatsApp number. It will be shared on the screen very soon. You can send your questions and inquiries, but BSV, they have a booth downstairs. Make sure to pass by for more information. I hope that is very clear. Ladies and gentlemen, since SAMK is a special occasion, we are graced with our guest of honor in both 2 days. Let's put our hands together again for Dr. Mpoki Ulusubisia for gracing us today. He's going to be doing a talk on critical care in Tanzania and the role of capacity building. Thank you very much, Doctor.
I want to thank the organizers for inviting me to talk a little bit about a topic that is very close to my heart. This is different from telling people what this country has to offer. Now we are going into what we are capable of doing. And I want to thank God that there are so many people that have shown and developed and shown interest. And for that reason, I'll be talking on what I have entitled the gap in capacity building for critical care. And not just the gap, but one that has been forgotten. And there are many stories in this country when it comes to resilient health systems and establishment. A little bit of the message was shared yesterday, and originally the invitation was to do it on Wednesday, March 4th. And so I had prepared myself to use 2 slides from the presentation that was made by Osati. But knowing that 4th was not Wednesday but Thursday, made me to come with some sheets of paper that I'm going to leave behind so that you decide what to do with the details. Now, I believe by now all of us are aware that critical care services are offered to patients that are needy but who qualify for our brains and resources to be invested in them, because a diagnosis has been made that has indicated salvage upon nature of whatever disease these individuals are suffering from. So the organ may be central nervous system, peripheral nervous system, cardiovascular system, the GI, talk of the renals, those kind of things. That without such intervention, these individuals will, without a doubt, lose their lives. And because of this definition, I need to start by stressing on the fact that intensive care units are not wards in the hospital where very sick patients are taken to go and die. Why do I say this? It's because you know a relative has a stage 4 malignancy that is amenable to nothing. Basi labda kwani hatuwezi tukamweka pale ICU, and you know in siku za mwisho. So ICUs are not palliative wards for patients that are going to be assisted on their way out of this life towards Kinondoni-like facilities. We have to understand that it must be given the best of chances that such investment in caring for these patients is going to help them sustain life and therefore go back and lead normal lives in the society. It's for this reason that during the apartheid era, the South African government instituted a system that managed to provide an opportunity for all patients that were very sick in South Africa. And this was practiced in the Chris Baragwanath Hospital in Soweto, where patients were scored. So all patients with loss of consciousness secondary to trauma to the head and several other things in the body, sepsis, secondary to all those kind of things that can cause a threat to life, were taken, they were scored. If such a patient did not improve in the first 24 hours, irrespective of the admitting diagnosis, these individuals were moved to a place where they will wait to die peacefully, if there is anything like peaceful death. The reason for that was critical care setting are energy consuming, labor intensive, very, very, very costly institutions to run. That is why not every hospital will qualify to have one. I'm sometimes amazed, Dr. Fire, when somebody has 5 beds on which to care for patients. Alafu anasema niko na vitanda 2 kwa ajili ya ICU. It doesn't make sense. Crude definition is 10% of your beds must be dedicated to patients that are critically ill. So if you have 5 beds, how many beds will make to 5%? Okay, common knowledge tells us that you cannot. Now that is one. But also the setup must conform to standards that will allow for care of those patients without limiting the ability for mobility on the staff that are offering such services. There must be enough room to position equipment to offer services that these patients will need, without forgetting that such equipment must invariably have a ventilator, a suction machine, and then you can add anything else. Because short of a ventilator, all you are having is a high dependence unit. I believe that has been stressed in this meeting. But remember, artificial intelligence is human-made, meaning there has to be a brain before this intelligence can offer services. This is something that is happening in the first world. I don't want you to answer the question that I'm about to ask. Which world do we belong to as Tanzanians? So there has to be intentional investment done in our environment to bridge this gap. while we are building very, very attractive edifices for health delivery systems, we have ambulances, and we are investing in equipment, there has to be a brain behind this equipment that will make them useful. Otherwise, like we said yesterday, these are not going to be no different from the white elephants that are so many in this republic. We cannot afford to belong to a group of individuals that have decided to turn a blind eye on this pressing need. The more people live long, the more they will suffer from diseases that were not picked on those that died at the age of 40, 30, 20, 10, and the under 5s. The aging population that so many of us are almost subscribing to brings as to why we need to pay attention. In my research, I've come across a statement that stresses on the fact that the root cause in capacity building for critical care services in the lack of attention and investment in building capacity on individuals that are going to offer this kind of services. Sometimes it's motivated by ignorance, that people in positions of decision making are ignorant, and therefore they ignore the need for such investment to be made. But there are times that people are just lazy, because if you don't read, you don't know what you don't know. And you may be walking around priding yourself with a stethoscope around your neck and loving to be called a doctor everywhere you go, without a concomitant delivery of quality services that come with it. We cannot afford to ignore the need to train people to offer services to patients that are critically ill. Now, there are so many ways of doing this, and this is what I want to spend some time looking at, because this can be done locally, but we may not be 100% good to offer everything in-house that is in the country. We have to appreciate the fact that, like emergency medicine, we don't choose the kind of patients that will be admitted to our centers. And therefore, we need to deliberately train comprehensively all people that will be called service providers in ICU setting. Now, there are several ways of doing this, but what has been very effective and like a litmus test in the world is for people to go to school and learn how to care for these patients. What is referred to as a cheap option is the in-house training, where you train one person and every day he comes or she comes or they come to teach what they remember. The only danger with that approach is the only danger lies in the fact that if the memory fails, then that cohort of trainees will be less that aspect that these individuals did not remember. So what we need is a curriculum-based training that will empower these individuals with knowledge and a skill set that they can always make reference to in offering these services. Now, once these individuals have been trained, it is not enough to simply come from the university with a certificate. They need to know that education is very dynamic, and therefore the training must be persistent, it must be perpetual, it must continue. And since certification motivates people, all training must be certified. So certification must be mandatory. People without certification should know what punishment will follow them. Now, see vile watu wanachapa ile nani, no, but I mean promotions and all those kind of things will be affected in the process. Now, we have to appreciate the fact that there will be a need for investment in certain specialized training. Yesterday we saw in a slide that Alicia projected here that we recognize the basic training for specialization, but a super specialization in a given field. That also must be put in place. While training is taking place, teamwork, collaboration must be incepted in the mind of people that are being trained to offer such services. The reason for this is very simple. This world is never served by one individual. Yesterday we had a lady that came from the management of this hotel with no idea of what is happening in medicine, much as she was called a doctor. Why do you think a presence here was necessary? It's because of the ambience that we have in here. Next time we come to request for a venue, you suppose she will think twice? She'll say, oh, if you are the people, come. We need her presence. We need cooks in this hotel. So the same way, we need everybody on the bandwagon. So we need doctors, we need nurses, we need physiotherapists like we said yesterday, we need radiologists, and we need people from the lab. Clergy not to be left behind. Why? Because most patients are too sick for mere counseling to suffice. We need that spiritual aspect. This must be a portion to the staff that will offer services. The reason for this will team building removes burden from one individual, spreads it out to so many shoulders. And so if anything goes bad, it's the team that suffers. But if you are the only person doing this thing, very, very often than not, blames will go to such particular individuals. There has to be regular team meetings, but those meetings should not be political. They should not be kangaroo courts. They should be places where knowledge is exchanged and the revisions are made on things that were done, whether they were done appropriately or they were not done appropriately, for people to learn. Remember, I'm talking about the forgotten gap capacity building for critical care in this country. The other one is, we cannot afford to have people carrying themselves around with a brand of critical care service providers without core competencies. Dr. Fah just reminded us here that you shouldn't look at yourself to be up there while where you belong is on the ground. It feels very good to think that you're flying, but I think that is just essential in the dreamland. Don't you think so? In real life, if you want to fly, man, you need to be in the aeroplane. So when it comes to service delivery, remember, core competencies must be a must. So leaders of teams here must make sure that people who work with them have those competencies. Those who are short must be trained, and the decision to train must be deliberate. Do not accept to engage people that are not knowledgeable. They are going to spoil the hard work that people invest in doing in such centers. And so it's necessary that core competencies must be there. Critical thinking, problem solving, clinical skills, and patient safety, which now has taken a different paradigm in our service delivery models. Let's not forget that we need to institute a regular assessment of these competencies among the staff that we are working with. Don't be scared, because when you assess staff under you, somebody will be assessing you as well. So there's no end to this. If our institutions will be certified internationally, we cannot avoid to assess the capacity at our disposal in delivering those services. And the only way that we can do this is by ensuring that competencies are essentially worked upon. There has to be a mechanism for continuous quality improvement. Now, we talk a lot about continuous professional development. This time is quality. Yesterday we were discussing about a certain progress at the center where I'm working. We looked at the number of people that came to the hospital same period last year, those who left with their lives, and those who were not so fortunate. We were very delighted because the numbers are falling, meaning that the input of care and interventions is in keeping with their sicknesses. That is something that has to be done regularly. When we stop to advance. We shouldn't be ashamed to learn that we don't know, and that something at our disposal is not good. We also need to include emotional support and the well-being of staff. I'm not talking of relatives with patients that are critically ill in the ICU. I'm talking of service providers. Margaret, you know, staff sometimes go 18 hours, non-stop working from morning. Whole day, somebody was meant to come to relieve them for some reason. They've had an issue, mtoto aligonjeka. So anasema, unajua, I'm very sorry, I wanted to come, and you can't leave those patients. Emotional support is very crucial. When patients die, members of staff must be supported. I'll share with you a story that happened to me when I was training someplace. We lost a patient on the table. A very, very unusual thing to happen in such a country. It was a first world. This gentleman was in their 80s with a very big, the aneurysm of the aorta of the abdomen, AAA. They had that disease for over 15 years. Then it came to a place where there was a need for this to be operated upon. Unfortunately, the disease process had ruined the tissue so much that there was no place to anchor the sutures when the graft was being sutured. So if they started on the east going to the west, by the time they come to the west, the east is up, and this guy was just bleeding. We were privileged to have 35 units of blood. FFPs, I can't remember the number. Now this should tell you it was not in Tanzania for sure. Because I'm seeing people, what? 35? Yes, one patient. And we would have had more if we needed, because wenzetu tunajua kutoa damu si kitu ya kesi. All right, so eventually this elderly white man became paper white. He died on the table. All right, so tukamaliza, najua nini. By then sisi ndo tulikuwa kutumano hapo Sankara. Tulikuwa na hey, leta kitu ingine basi. So the guy or the body was taken from theater and funeral home. The next day I was at work 7 in the morning. That specialist was in charge of that case did not come to work. Third day he did not come to work. So he came to work on Friday. When he arrived, everybody empathized with him. Ulishaona hiyo hapo unafanya kazi? Dr. Fire, the late Dr. Lueno lost 2 patients in a row, and he still continued to work. We need to create mechanisms now that will make people feel wanted, loved, cared for at our place of work. Tusifanye mazingira watu anasubiri kurudi nyumbani akapate ile compassion. Kama kuna challenge ya kazi, hiyo compassion yapate mahali gani? Kazini. That is the kind of capacity we need to build in this country. Leaders should not be seen as policemen and women. They should be seen as enablers in our place of environment. How do we make this? How do we make this kind of people? By training them. And we have to train them appropriately. The other thing that we need to be careful about is advanced technologies and equipment. I spoke about artificial intelligence, and some of you were scared because some mnajua kazi yenu itaibiwa. No. They will still need somebody to have a stethoscope to listen to breath sounds, listen to heart sounds, to correlate with what the machine is saying, to provide diagnosis, to draw specimen, to process this specimen before they are taken to the lab. We need to prepare a people that will stay up to date. Now, listen very carefully. Have you seen the kind of cars that our leaders are being driven in? Nimewauliza, mbona majibu? Are they old-fashioned jalopies? And then when they are sick, where do they go to for treatment? What I'm trying to say is, usije ukafikiri kwamba no, this is too expensive. Life is the only expensive commodity in life. Life is the only expensive commodity in life. Don't be scared of technology. Embrace it. Recently, we had a meeting, international meeting where professionals in anesthesia and critical care met in Singapore. I was surprised to see a machine that responds to verbal commands. Hasa nilijua mtakuwa hivyo hivyo mmefanya. So I had to take a video. And I made sure Logazia was in my company ili msije mkasema hicho ila dijitengeneza peke yake. No. So I would tell, please zoom in. Save. Print. Inazungumza tu. Na mind you, this ni English ya Mnyakyusa nazungumza, but the machine understood. So we cannot afford not to know that such technologies exist. So this idea of increase the depth in an echo machine or ultrasound, it's no longer an issue that needs you to know which button to press. It's just a question of you telling the machine, this image is too bright, darken it. Scale. And then M mode, it goes to the M mode. And if you've made a mistake, the artificial intelligence will tell you, please indicate where. Sasa ukifanya kama mara 10 si utakuwa expert. Alafu unasema hey, yule mtaalamu bwana akanaambia mashine inafanya yenyewe. You get some pride. So we need to ensure that staff receive proper training in operating and utilizing such technology effectively. We also need to base our practice on research and evidence base. Meaning that there are pools of knowledge around the world, but some of those technologies relate to where such researches were done. A time has come for us to say, when our patients come from theater with arrhythmias, amiodarone doesn't seem to simply solve the problem. In our environment, it is digoxin and digoxin. But I mean, no, I'm saying in our environment. How did you know? We've conducted research and we have shown without any doubt that such drugs will be very good. We should not forget that leadership is developed. Now, so many of you are cheated that people are born leaders. Tell me of a person that you know that was born a leader without receiving any training. But I can tell you, dictators are born dictators. I'm not talking of managers, I'm talking of leaders. You know what a leader does? He runs teams. And the teams stand for together. Each achieves more. So everybody feels they are part to the equation. Kazi ikifanyika mzuri, credits wanapata wote. Ikifanyika mbaya, wote wanalaumiwa. No fingers. Ya Rama alitakiwa kuwa hapa, lakini unajua amependa, unajua ni mtu saa yote ako nje, yani mtukano ameenda Mwanza nini. No. It doesn't work like that. So leadership must be developed. If I asked a question here, what is the best thing that you need done in the course of your work to make you happy in your place of work? A majority of us will say, nyongeza ya. Nilijua. Sababu hata mimi hiyo ndio nasubiri kila siku. Yeah, unfortunately, we need to engage staff, but also we need to recognize. Recognition is the most important reward any employee needs. When the gentleman that presented here on BSV started by saying what? I thank Ramadhani for reaching out to me. You think Ramadan was feeling sad? He felt good. Just recognition. Staff that perform more should be recognized more, and others may need some push to reach the same staff. There are certain facilities where people post pictures, mfanyakazi wa mwezi, mfanyakazi wa mwaka, yeah, na certificates. You write those certificates when people achieve goals. Now, you may ask yourself, why am I talking about this when it comes to capacity building? Those are the things that need to be included when we train these people who are going to run such services. We need to celebrate them, but also we need to encourage them to develop others. When people are not celebrated, they leave. And many good people have left. I was reading something early this morning about a person that committed suicide. A good man, came to work every day and delivered very well. But for 20 solid years, nobody ever mentioned to them that they valued what he was doing. So they went to his accounts, they were clean, his house neat, but in his body there was a note. He said, man, for the 20 years I've worked here, nobody has ever appreciated my services. I don't think I'm needed around here. He committed suicide. We shouldn't do that. Last but not least, there has to be an interprofessional collaboration. When we train these individuals, be they nurses, be they doctors, whoever, let them know they cannot serve patients on their own. There has to be room for people to collaborate. And our ears must be open 24/7. Last week we had a patient that was vomiting post-operatively. And naturally, we say the ondansetron will be the best thing. Yeah, 5-HT receptor antagonist. Yeah, it was given. Half an hour later, vomited. Oh, okay, fine. In that case, then do dexamethasone. 30 minutes later, and then a humble nurse whispered to me, Dr. Mpoke, mmejaribu metoclopramide. I said, ni hiyo. We gave that medication, the patient stopped pewing, they ate, they felt strong, they left. Knowledge-based practice is the motivation for capacity building. I believe when these 10 points are put together, we shall have better staff offering services in critical care settings. Thank you very much for your time.
Ladies and gentlemen, let's put our hands together again to Dr. Mpoki for a wonderful presentation. Doctor, I just want to say a few things before you leave. Just bear with us. Just a few things. They say in Swahili, tukupe maua yako. So I picked a few things from your presentation, and I want you to hear this. Some other professions, not people from EM and critical care units, they normally have the husband and wife at work. Do you recommend that for our staff? For the passion and compassion that you have been explaining? I'll leave that for the discussion. And to allow you to go, there's a machine I came across. It's a quantum magnetic analyzer. And one of the areas it analyzes is the human conscious levels. I was surprised to see that machine can analyze our level of happiness, peace, joy. I believe such machines can be available also for our staff and help them understand their feelings after tireless shifts. I allow you now to take your leave. Let's put our hands together again for Dr. Mpoki. had made 4 points for Dr. Mpoki. I'll finish the 2 with you guys. One extra point, he spoke about recognition at workplaces, and he spoke the point where we post pictures. I know when we take this discussion to our departments, it might take a lot of time. Let's start by posting our own pictures on the walls, and then the discussion will follow. Ladies and gentlemen, up next is our beloved Dr. Ramadhani Chunga, and he's going to take us through a very nice presentation on the ultimate chain of saving lives and the thin line between emergency medicine departments and critical care units.
Good afternoon. Is there any, we are all in Tanzania. Do you see the difference between ICU and emergency medicine department? Do you see any difference? Probably not. But do all these machines help us to save lives? Does a critical care unit really matter to the number of patients that come to hospital? Probably not. Do cardiologists, emergency physicians, and maybe neurosurgeons that we produce are enough in saving life? So let's look at the ultimate chain of saving life. Well, sometimes when things happen, actually we cannot hide. We cannot hide to succumb anything. Emergencies happen everywhere. You cannot hide. You can go to wherever you want to go, but emergencies can happen. But whenever it happens, wherever it happens, things must be done to save a life. So we must switch. Our system should be created to switch that. Whether it's under the car, in the ocean, in the plane, wherever, there must be a system to be resilient enough to save a life. So you can see how much capacity we need to build. Do we have people that can save a life in the road? Not yet. Do we have people that can save a life in the ocean? Yes, but not yet. We have seen the issues happen in Mwanza. The person who was congratulated for saving a life was not a doctor, was not a paramedic, was just a person. We are physicians. We should be the one to do that. And therefore, we should capacity build to fill in that gap. And there are so many circumstances that we can see that we can capacity build and help to sustain life. Well, we'll be talking about peri-arrest. We'll be talking about high-quality resuscitation. We'll be talking about post-cardiac arrest care. These are important elements. And to be honest with you, I'm not talking about cardiac arrest. Because whenever anything happens, our body tries to compensate. And when compensation mechanisms fail, it will decompensate, and further, something more will happen. Our job as clinicians in every way we go is to make sure we identify compensatory mechanism that the patient comes with, we resuscitate, and the person will go into the right direction. What does that mean? If that is the case, who is the most important person in saving life? Let's look like that. Let's imagine we do have any person that we know has got any HE, any T's that we know about. Who do we need the most? Looking at the chain of saving life, we say the most important part is surveillance. Surveillance is monitoring. Let's say we do have a patient who is in the ward. This person was admitted either from theater or was admitted for pneumonia. What do? We ask a nurse, please can we chart vital signs every 4 hours? Or sometimes every 2 hours or 1 hour, or in ICU every minute. That is surveillance. And usually that means the system should allow that if things don't go in the right direction, the physician, the nurse, or the doctor who is on call or who is with the patient is activating emergency response to respond to that situation. Failure to that, the patient will decompensate. So surveillance becomes key to everyone. And this surveillance can be pre-hospital when the patient is home. That's why you see patients are saying, say, every 2 weeks come to hospital, I need to see you. The OPD is a surveillance system. You need to have a patient who comes in and you can check if things are not going well. Sometimes you have to do electrolytes. For example, though dialysis patient, you have to check for potassium, you have to check all these things. So you're doing surveillance. Similarly, we have got clinics, wards, waiting rooms. We do have patients sometimes in waiting rooms and they die. If you don't have someone to watch them, they may be hypotensive, they may collapse there because of their patient. So we need also to provide surveillance in waiting rooms. Moving forward, let's say someone comes to hospital and has shortness of breath or anything that made them to come to hospital. The key to saving or providing care is actually identifying what is actually the problem. Because a shortness of breath, you know, if I ask you, it could be pneumonia, it could be acute coronary syndrome, it could be just anxiety, it could be anything. But the treatment of anxiety, the treatment of acute coronary syndrome, the treatment of pneumonia, the treatment of pulmonary edema is quite different. The power to the doctor or to the treating physician is to recognize that this person has got acute coronary syndrome. So if we recognize, immediate recognition helps into early resuscitation. Most of the problem, we lose our patient because of late recognition and late resuscitation. And sometimes we treat complication because of late treatment. And this is, you can see, someone come with diarrhea in the hospital, has lost a lot of fluids or is vomiting, a loss of fluids. We are unable to identify the hypovolemia. We are unable to treat the immediate complication, acute kidney injury. And what is going to happen? This person is going to go to a long-term kidney injury, into CKD, and in the end, the person end up into requiring dialysis for the rest of his life. So, key here, early recognition of hypovolemic state, rehydrate with the fluids, check creatinine how it goes, and then in the end of the day, you will come up to see this person, and usually it will resolve very quickly, and you see the person can be discharged healthily home there than requiring dialysis. Then, after early resuscitation, then sometimes you need advanced life support as well. For example, we do have a person come in, have got abdominal pain, is vomiting. You have checked everything. This person does not acute pulmonary syndrome, does not have anything. You think this person has got appendicitis. And then definitely you appropriately consult or with your physician and surgeons, and they will agree that this person requires surgery. Surgery is advanced life support. It's not a basic life support. Basic life support is to give fluids, to resuscitate this person who is hypovolemic, to assist this person with pain, and all these are basic maneuvers. But advanced is when the surgeon comes in, that's advanced. Not everyone can produce. So that's the intervention we're talking about. If you are talking about a person who has got acute coronary syndrome, then rapid intervention is to get this person to cath lab. If you're talking about a person who is having like the surgical issue, to go to surgery. As you can see, the first three links of saving lives, anyone in this room, irrespective of you are a specialist, you can do this. You don't need Dr. Fire to do that. And mostly, you need a nurse at some point, you need a family member most of the time, okay? You need an ambulance provider, you need a junior doctor, and ward teams. And I can tell you, these are the back of our system. Specialists, you can have 2 or 3 specialists for the whole hospital. You can have 3 or 4 emergency physicians or 1 emergency physician for the whole hospital. But most are nurses, junior doctors are the ones. So if I ask you, where should we invest more? Where should we capacity build more? We should capacity build non-specialist people in our hospital. We do have people who are actually porters, for example. Do you think a porter cannot help us with the CPR? Can do. Do we train them? We have got radiographers. If someone collapses in radiology, who does help? It is a radiographer. Do we actually train them to assist us when you know what has happened sometimes? People, EMD people, please come. They're at radiology. Someone collapsed. We don't have that time, that luxury in saving someone's life. So it means everyone around us should be able to save. I can also give you more important example. Our own family, our own wives, our own husbands. At night, you have acute coronary syndrome, chest pain. What do you do? What do they do? You know what they do? Oh, I think you need something to drink. They bring you water. Because always in our society, people have got reasons for everything. They provide, I think you did not eat. Someone is having kiunguria, or is having it's PUD. Actually, someone has got an inferior MI, and he actually is going to die. That's why you can have, if we do research, and this is what has been called upon by Dr. Mkop, we should do research. We should answer our own questions. We should not be answering questions from America. How many times you receive people who died from home? How many times? Maybe a lot of time, someone died at home. No one dies at home because of appendicitis. No one dies home because of diarrhea. People die home because of simple things. And probably acute coronary syndrome. But we have been told since, oh no, it's only malaria here kills people. No, there is acute coronary syndrome, even to kids. Go to JKCI. Find the data from JKCI. Find data to cath lab areas. They will tell you more. So let's go back and train our families, even to smaller things. Ban. I also sometimes say, you know what? I'm emergency physicians here. My wife is an emergency physician. You are maybe a critical care specialist or whatever. But who is taking care of your child at home? You've got 2 beautiful children. But these are taken care by someone who came from there, in the village there. There's no even trained personnel who's taking care of a professor who's working in the university. You know what happened when they're feeding porridge? When the child does not want to eat, you know what they do? They close the nose. You know what happened? These 2 systems are so intelligent. Epiglottis is very intelligent stuff. And by doing that, you're confusing it. Because when you swallow, actually it closes. Right? And when you talk, it opens. When the child is crying, it means it's opened. So when you're throwing food, there is a chance of going to the airway. So what are you doing? So that's what I'm saying. We need to invest capacity build, not only us, even to our families. Burns. You know what happens when someone is burning? When burn is exposed to the skin, it penetrates through to the bone. That's why you get layers. So the most important thing when a burn happens, to cool. But what happened? People take my eye, what is asari, What is Asali doing? Thank you. Okay, so then the rest of the system is the advanced providers. The advanced providers, these are JKCI, CathLab, they provide a very small part of care. And when you talk of quality of care, you are talking of these people here. These here are usually very good. That's why I can tell you, if you go to JKCI or a facility of the like, people appreciate going there because specialists are not as other people. Because usually knowledge means a lot. When you know, you cannot be rude. When you know this person is sick, you cannot be rude. But when you don't know, how come someone ajifanyisha afu aje saa sita usiku nyumbani, aje saa sita usiku hospitali? How come someone akajifanyisha akaja saa 8 usiku? People don't want to sleep. When you see someone coming at night, this person is sick. Your mood and your attitude towards that should reflect that this person is in trouble. You need to assist. Even if you don't find it, you say, no. I've checked this, I've checked that, but I didn't find anything. But this person, let me admit, I need to check on this tomorrow. It's not a person for admission. It's not a person for discharge. I only discharge a person that I know what is going on. I don't discharge a person who comes in and I don't know what is happening and is having a chest pain. There must be some things hiding. So keep there, get the mind fresh. Your colleague you're going to see in the morning, then you can be discharged. You can even admit in the ED, in the emergency department. That's why there is a concept of short stay wards in emergency department, which we can talk about that. And we can have that a different view. So I want to welcome you, my colleagues, that these principles, let's capacity build our team, and especially those colleagues who are emergency physicians here. Let's train your teams, train people that are working close to you, and that's going to be very good, and it's going to work very well. Basic life support always is where everything happens. If you fix the basics, advanced things won't come. And that I don't mean cardiac arrest. Cardiac arrest is not something that we should be speaking about, because when someone goes to cardiac arrest, something failed, either monitoring, resuscitation. So we're not talking about a failure. We're not trying to fix our failures. We want to fix before the person collapses. So we're teaching you BLS, we're teaching you, but we're not teaching you that you should wait a person to die, you do chest compression. After all, you need 6 people to be on one person to have this person have passed back. But these people is a lot. Why should you spend all that time? But only one person can resuscitate the person, come back into a normal self without needing all other sources. So basically, we spoke about all these things, and it has been covered in the lessons that we are doing, and the importance of chest compression. We spoke yesterday, and we also today, some of you are in the SLS and the PAWS, and many that are involved in airway management and ECG interpretation, but most of the time you don't want to follow your patient to the grave. There's a time you have to say, no, this is enough and enough, but let's reach this time when everything has been done. Thank you so much.
Let's put our hands together once again for Dr. Ramadhani Chunga. Thank you very much, Dr. Rama. 2 points I picked from your presentation, wonderful presentation, was you have a wife who is also an MD physician. That is all I'll take home with me. I urge all those singles and aka bachelors, do not be senior bachelors. Get a wife or a husband from your department. It will ease your work, but also taking care of home shifts. And the second item that I picked was the seriousness when patients present at the emergency department in midnight. I worked at a certain hospital sometime many years ago, my friends. And I remember my colleague were doing shift together, and what we decided was whoever comes to the hospital past midnight, they should not go home. Regardless, you have tested, diagnosed, allow them to stay for observation, at least for the next 8 or 12 hours. Okay? So doctor has said, don't take it as at ease. If somebody presents at emergency department in the middle of the night and you just take it easy. They could not sleep at their homes, means they found a bed at the hospital. Please give them those beds. Once again, thank you very much, Doctor. My dear colleagues, as we wind up our afternoon session, day 2, I would like to invite our dearest friend and colleague also in assisting our patients and taking care, improving quality and also service provision. An occupational therapist, our dearest Mr. Godfrey Kimati. Please, let's put our hands together as he approaches.
Hello. How are you? Ramadan Kareem, everyone. My name is Godfrey Kimati. I'm an occupational therapist from Muhimbili National Hospital, and I'm very happy to be here with you. Very proud to be in front of Dr. Fire today. So my first question to you when I was coming here, I was thinking, where would I start with this presentation today? Since most of you might have heard about occupational therapy, but as well confusing it with physiotherapy, sometimes with behavioral therapy. But today I wanted to at least enlighten you about what occupational therapy really is, and especially in critical care. So the first question to you, when you wake up today in the morning, was there someone who helped you to get off the bed? Someone who was helped to get off the bed today? Is there anyone? No. Is there anyone who was helped to brush their teeth today in the morning? Anyone? Is there anyone who would like to be brushed their teeth? Someone who would like to be brushed their teeth? Someone to be combed their hair? Someone? The lady here. Nice. So from this population, only one lady would like to be combed their hair, but the majority of us would like things to be done by ourselves, right? You'd like to be doing things by yourself. Now, when we are talking about occupational therapy, it's about things that you do from the time you wake up to the time you are going to sleep. That's occupation. So imagine about your patient who is actually being attended by you at the clinic, actually at your clinic, or has come for critical care services. Are they comfortable for things to be done for them? Start to think about that. When they've had maybe incontinence, are they happy for such situation to happen to them? And when you are thinking about that, try to put yourself in their positions. Now, when we are talking about occupational therapy in critical care services, we are looking about when a patient has suffered and is being attended for critical care, there are several things that they start to experience. One, they may have suffered about their muscle weakness can start to deteriorate their muscle capacity, and occupational therapists would really help this patient from the foregoing to ensure that they equip their muscle strength before it deteriorates to a point whereby it will lead to disability. That's the first thing. Another area where these patients who are coming to us for critical care, another area where they may be affected is their cognitive function. I do believe you might have faced patients who have suffered they are going to have cognitive impairment, and at this early stage, this is when occupational therapists would help this patient to ensure that first, they assess their cognitive function, and second, they start to do interventions that will equip their cognitive function from deteriorating. Another area where these patients that we receive for our critical care services, where they may inquire to have occupational therapy interventions, is when they start losing their functional skills. I do believe patient that you see, you may be ordering a nurse, maybe go turn the patient every after 2 hours, yeah? Make sure that the patient is being fed. But have you ever thought or think that the feeding skill will be lost by the time this patient is being discharged from your critical care services? So by the time this patient is being attended for critical care services, they may be requiring to ensure that their functional skills are being maintained, and functional skills about everything that you are doing from the time when you wake up. How do you pick your clothes? How do you put them on? And how do you get out of the house? All these function, by the time this patient is being admitted to the hospital, there is a chance that it may deteriorate and they may lose these functions. So you need to have, when you have an occupational therapist in your team, they will work with you to make sure that these functions have been maintained. Another area which occupational therapists will work with you is on the area of self-care. How often in our critical care services do we see our patients brush their teeth by themselves? How often? Does the nurse does that? Would the patient want to do that by themselves? Have you ever had a patient who can have the skill to do that by themselves? So these are the questions that you need to ask yourself while you are at the critical care services to ensure that this patient, by the time that they are there, their dignity is being maintained, their sense of worthiness is being maintained. So another area that I wanted to make a little bit of insisting on is on the area of cognitive function, which I had said a little bit. Our patient, when they have effect happens in their cognitive function, they may lose several factors. One, they may lose their sensory motor skills, they may lose their fine motor skills, and this is a point where an occupational therapist can really help to maintain this function from being lost. And finally, one area that is of importance that I wanted to talk to you, it's about the area of sensory processing. So sensory processing, it's about how you receive your senses from the environment through your sense organs and how you process it to have a good, proper outcome from how your brain has processed the information that has been received. Now, one among the issues that we see in patients who have been long time admitted in critical care, its effect on their sensory processing. So now we know we have 5 senses that process and receive our stimuli and process it to get feedback. But as well, have you ever seen a child who has been long time admitted for critical care services, and once has been discharged, you see parents start complaining that my child has lost their speech skills, my child has lost their fine motor skills, right now is more hyperactive. Have you ever heard of such information from your parents, from your patients? So these are the kinds of interventions, if they were done earlier while the child was still at the critical care unit, would have been addressed prior and to maintain those functions. Because our senses, yes, we see 5 senses, but there are other senses like vestibular processing skills where the kids who have been in the ICU or have been in critical care for longest of time, they may have suffered from losing their vestibular skills. So they will need to be maintained when they're still in the critical care units. As well, to adults, they may reach a point by the time, if the patient has had NGT for the longest time, they may lose their speech skills, but by the time while this patient is still at the critical care, when the sensory intervention is being done to them, may have higher chance to maintain their speech skills. Another area where you may find our patients are suffering from in sensory integration is their proprioceptive skills. You and I right now, our brain feels that we've occupied space through our joints, our muscles, our tendons. But by the time this patient has been admitted for the longest time in the ward, they may start losing their proprioceptive skills, whereby if you include occupational therapists while this patient is in critical care, the chances to maintain their proprioceptive skills could have been higher, and by the time this patient has been discharged, the proprioception, feeling their body in position, will be maintained. And finally, one area of importance that I wanted to insist for engaging occupational therapists in your critical care services is on the transfer of the patient. Training patients, proper transfer while they are still in the critical care services. This can be transferring from bed to sitting position to lying position, to ensure that the patient does not succumb further deterioration. Thank you very much for listening to me, and thank you very much for having me here.
Thank you very much, Godfrey. Let's put our hands together once again for Godfrey. Do you want to know what I picked from Godfrey's presentation? I'll tell you tomorrow. We need to go back to our breakout sessions, but I am aware that a few of you did not manage to grab your lunch. For those having your lunch, please, the buffet is still on. And before we leave, Dr. Rama, please.
Okay, so we'll be moving back to our breakout sessions, and I would like to request the facilitators to come and stand here so that we can give them hands of their good leading in our sessions. Please, facilitators. Facilitators. These are great people that have come to impact our skills and the knowledge, and we cannot walk without saying thanks to them. And I can tell you, it is multi-hospital, multi-discipline, multi-everything. And I would like to recognize everyone and ask them to speak something and say where they're coming from so that we can understand why we want to knowledge share from each one of us.
Good afternoon, everyone. My name is Dr. Moiz Adamji. I'm an emergency physician. I'm the head of department of Shifa Pan African Hospital. I'm running the emergency department and critical care unit right now. Thank you, and thank you, Ramadhani, for this opportunity. It has really enlightened me, especially Dr. Mpoki's speech. He has given me a new light today. Thank you so much for this opportunity.
Good afternoon, everyone. My name is Dr. Teresia Lutufio. I'm an intensivist at Muhimbili National Hospital, Mloganzila. Thank you, Dr. Ramadhani, for this opportunity. I have met so many people, and I have taken so many points from Dr. Mpoki, especially going abroad, acquire skills. And I think it's important. You go abroad, acquire skills, and introduce those skills to your field here in Tanzania. Thank you. And you're all welcome. I hope we will have other sessions where you will be welcome again. And I hope you're going to practice what we are teaching you here. It's not going to be the end.
Hello, everyone. My name's Dr. Masuma Gulamusen, an emergency physician from Muhimbili National Hospital, the campus in Mloganzila. I'm happy to be here with all of you. For the next 2 days, today and tomorrow, I am an instructor in the PULSE course, and I'm sure most of you who are with me there, we've had a fun time.
Hello everyone, my name is Asha Yulu. I'm an emergency physician from Muhimbili National Hospital, Mloganzila campus. I'm also happy to be here, and thank you, Dr. Rama, very much for this opportunity to be here as both facilitator and also I'm networking with other people.
Hello everyone, my name is Dr. Marco Erasto Nyakasel. I'm intensivist from National Hospital Muhimbili at Upanga. Thank you so much, you're welcome.
I wear two hats. The first hat, all of you have known me through the first hat, chairman of EMSA, the organizers of this particular symposium. And the second hat, I'm a private physician, a private orthopedic surgeon in private practice. I practice at London Hospital and High Tech Hospital. I used to be at TMJ, now slowing down. Years are catching on. Thank you.
Hello, my name is Winnie Mdundo. I'm also an emergency physician. I work at Muhimbili National Hospital, Mloganzila. I've been there for like 7 years now. So thank you for the opportunity to change the scenery and meet new people and have fun in BLS and Pulse. Thank you.
Yes, good afternoon. My name is Dr. Bita Mwanuz. I'm working with the Muhimbili National Hospital in the Emergency Medicine Department. In this symposium, I'm facilitating basics class. Thank you.
Hello, everyone. So I'm Dr. Shamila Regoshora from Jakaya Kikwete Cardiac Institute, Emergency and Critical Care Unit. I want to thank Rama, mkwe wangu, for giving me this opportunity. So my request is for each one of you to share this knowledge, as Rama said. Thank you.
Hello, everyone. My name is Ramadan Chaule, working at Muhimbili Orthopedic Institute as an anesthetist. I'm working in the anesthesia department, HDU, EMD, and ICU somehow. I would thank Dr. Ramachunga and Dr. Fire for inviting me in this symposium, and I would like to call for you guys to call others. As you see, this cause is very important to us, and for the other fellows, we used to work with them. Thank you. You are welcome.
Hello. Good afternoon again. I'm Dr. Ruben Mkama. I work at Muhimbili National Hospital, Mloganzila, as an intensivist. Actually, in our unit department, we are only 2 intensivists current now in Mloganzila. And we have a team of 4 registrars who are a part of us. And currently, we want to start and introducing a pediatric ICU. It has been a privilege for me to be here. I thank Dr. Ramazan and every member here for what we have learned and shared together, but also I thank you guys. We have learned together, exchange ideas, which is something amazing. What I want to say, what you learn here, we should not forget it here. We have to put it in our practice. Because as doctors, we have a lot of knowledge, but sometimes we don't use it practically. We're just saying like, oh, this, but you'll be standing far away. So let's practice more and more. Thank you so much.
One more person.
I'm Moses Dabre. I'm from Saifi Hospital. I'm biomedical engineer. I came here for ventilators support. Okay. Thank you. And thank you, Dr. Rama, for calling me. Thank you.
Thank you. So basically, all of us here, if we can clap hands for Saifi Hospital, has contributed all of the intellectuals we are playing with them here, which is a very good multi-hospital team approach. You can see the whole of Muhimbili engine is here. You can see from Shifa, the new hospital coming in. You have seen Saifi is here, and that's the purpose of having SEMC. Same thing, we want to knowledge share among us, because the strength Dr. Fire has, you have heard. The strength Malco has, you may not see Dr. Malco until you get very sick. You want to see him, I'm telling you, this is the only opportunity that we can see him. So let's spend a lot of time asking many questions as we can. And mostly, you won't see me at all until we talk here. So definitely, let's share the knowledge together. Let's show the experience, and we can continue having all these things. So thank you so much, colleagues. I really appreciate for the time that you have invested. I know you may be having a patient today, and you said, no, let me go and impart my knowledge to other colleagues. This is a big investment that we are doing in, and let's continue doing the same. So thank you so much, please.